So it's now my pleasure to introduce Dr. Sarah Grahn. Dr. Grahn is my partner in the South region, practicing out of Edina and Burnsville, and she initially asked if I could just come up here and say her name and then walk away from the podium, and I thought to myself, I can't really do that because she's been such an important part of my life. She was my senior partner, though only a couple years senior to me as I started out in Edina, and she's really been an amazing mentor to me, and she's going to talk to us about IBD and cancer risk. Show me the data. Dr. Grahn.
I have no disclosures. Today we're going to go over the incidence of colon and rectal cancer and inflammatory bowel disease. We'll review the risk factors and discuss what we know about the pathogenesis. Issues of surveillance will be discussed in the dysplasia discussion next. We'll touch on some medications and surgery as well. The association of inflammatory bowel disease and colorectal cancer has been acknowledged for over a century and is thought to be promoted by chronic inflammation in combination with a genetic predisposition. The magnitude of risk remains a subject of debate. Given this presumed risk, goals of medical care in these patients are to identify those at risk, modify that risk with medications, as we've just discussed, and institute a surveillance program to intervene early in cancer, as the sequence of disease is often unpredictable in these patients. In 2001, the incidence of colon cancer in IBD patients was reported at nearly 20% at 30 years. This study was based on a tertiary referral care center and probably disproportionately represented high-risk patients with severe disease. More recently, a meta-analysis published in 2012 demonstrated a roughly anywhere from 1 to 5% risk at 20 years. A Danish meta-analysis study looking at solely population-based studies even suggested an absence of increased risk over the general population in their study group with a relative risk of 1.07, with an absolute risk of about 3% at 25 years. This was a graphic image of the data that our risk may be declining over time, and again may represent that the risk depends on who you're looking at. This French study showed a twofold increased risk in colon and rectal cancer and IBD over a general population that was similar in both ulcerative colitis and Crohn's disease. But when they looked more closely at their data, they saw that this increased risk was found in a relatively small percentage, just 15% of their patients that had this increased risk, and could be categorized as those with long-standing colitis greater than 10 years or those with greater than 50% of the colon affected, compared to a non-significant increased risk in those patients without those risk factors. In looking at why the rates perhaps are declining over time, this may be multifactorial, particularly related to our increased clinical awareness, better medical control of the chronic inflammation, and aggressive surveillance that will be discussed next. The reduction of cancer may also be related to use of colectomy for dysplasia, and as previously discussed in deciding on which patients to operate on requires a balance of looking at these predictive factors for synchronous and metachronous cancer, but also the morbidity associated with the colectomy itself. And careful risk stratification, counseling, and surveillance, along with surgery, is sometimes needed. The rates of synchronous cancer are variable, and studies reported as high as 70% of those with dysplasia may have cancer. But these were, again, early reports from tertiary care centers and prompted a big push towards prophylactic colectomy. Populations where there's a high rate of colectomy, the cumulative probability of cancer is about 2% at 30 years, and this seems pretty good compared to those much higher rates that we'd previously looked at. In 2005, just reported an estimated risk of about 1.9 for those with colitis, particularly those with colitis had an increased risk of colon cancer, but not really thought to have an increased risk of rectal cancer. Crohn's affecting the colon did have a significant increased risk, whereas ileocolic disease had a non-significant but increased risk, and those with pure ileal disease did not have an increased risk of colon cancer in this study. Other meta-analysis also confirmed that colitis and the extent of disease really did affect the rates of colon cancer, ranging up to 11% at 30 years. And the site of disease did generally affect the location and risk factors. So looking at higher risk factors, we're going to kind of go through this in a little bit more detail, but the extent of disease definitely matters, whereas those with just isolated limited distal colitis had a relatively low increased risk of cancer, whereas as you increase the length, clearly the risk of cancer increased. Coexistent primary sclerosing cholangitis also has a higher cumulative increased risk of dysplasia and cancer, with up to 50% at 25 years can have cancer, making this a rich target for surveillance and aggressive early surgery. Family history also has an increased risk. Those with any first-degree family member with colon cancer had a twofold increased risk, or baseline, and those with a family member less than 50 had a relative risk of 9. Chronic inflammation was also thought to increase the risk of colon cancer, as we might suspect, and a retrospective study looking specifically at inflammatory scores showed that for each unit of increased inflammation in their score, they had a 3.8-fold increased risk in dysplasia and cancer over time. Additionally, some studies cite pseudopolyps as an increased risk, although this is somewhat variable, but some studies report a 2.5-fold increased risk for those with pseudopolyps. This can also make surveillance difficult in deciding what is inflammatory versus neoplastic. So in review, risk factors for cancer in colitis patients include longer duration, wider extent of disease, concomitant primary sclerosing cholangitis, family history, chronic inflammation, and colonic Crohn's over ileal Crohn's. So looking at the pathogenesis of inflammatory bowel disease-related cancers, it is very likely multifactorial and not well understood. There can be genetic, epigenetic, immune, oxidative, and microbial risk factors that come into play for these patients. The genetic mutations for colon cancer are often one or two single foci of abnormalities within the genes in these cells in your colon. However, colon cancer arising in colitis patients is very multifactorial and really more supporting a field change effect. Aneuploidy, which is a marker of genetic instability, is seen in dysplastic lesions in up to 50%, and in cancer patients up to 90%. Really, again, talking about the genetic component to this. And interestingly, looking at the genes in these cells, there can be substantial genetic alterations in the cells where the overlying mucosa appears normal, which makes surveillance and monitoring quite unsatisfying. This schema I took, and it's probably a little bit small to see, but the point is the top line here shows what we think of as the standard mutation pathway for sporadic colon cancer. And underneath here, I don't know, the bottom, below the line there, is the similar sorts of genetic mutations, but they're in an altered order. And this may contribute to our inability to predict time and rapidity of progression of these patients, again, making it difficult to predict when we should intervene and what we're likely to find. So how do we reduce these risks? Chemoprevention is, and it was somewhat discussed a little bit in the medication and suppressing inflammation, and that is often a goal where we're looking for mucosal healing, histological healing as the main therapeutic goals for colitis patients, and a rapid step up or top-down approach is often used depending on the severity, and monitoring and intervention should be tailored specifically to the patient's current status. So in this study from 2005, they noted a regular use of mesalamine was associated with a decreased risk of colon and rectal cancer. It was thought to work through effects on the cell cycle progression, trapping of reactive oxygen species, and also an antimicrobial activity. There are some conflicting studies about how much and how often, and different societies make different recommendations in terms of chemoprevention, but from my point of view, it seems like a good idea. Immunomodulators have not been clearly shown. The data is really mixed and not strong enough to make any strong recommendations for chemo prevention for immunomodulators. Similarly, biologics have the benefit of reducing inflammation, but they also cause immune suppression, which may have a mixed effect on cancer in these patients. Interestingly, when they look at population studies, statins have been shown to have a risk reduction for patients with inflammatory bowel disease, and only 2% of a large population developed cancer when they were using statins, whereas 3% of the non-users, and that was found to be statistically significant. The data on that's a little bit variable, as those who were on the statins had multiple comorbidities, so the effect might even be greater in a prospective study that are ongoing. And the use of ursodiol in those patients we talked about at high risk, the primary sclerosing cholangitis, is thought to bind up the bile acid, which is a known carcinogen, and had a quite significant reduction in dysplasia in the studies where that's done. There was, however, some reports of increased risk of cancer in patients with long-term high-dose ursodiol, and so caution there. It hasn't been studied in patients with ulcerative colitis without primary sclerosing cholangitis, so that could be an area of study. So in conclusion, the risks of colon cancer in colitis patients are probably not nearly as high as were in the textbook when I was starting. And chemo prevention should be certainly considered. The surveillance should be tailored based on the extent of disease, amount of inflammation, and surgery should be employed if needed. Thanks.